us know where you're signing in from, what city or state or country. We've got a great panel today, great discussion we have in front of us talking about nurse staffing, and we've got some great leaders here to talk about that, vaccinations, observations about just nurse staffing and just nurse leadership. Talking about several topics I have on my list here today. So I want to just go ahead and welcome them in. I got three of my guests now. I have one more we're adding a little bit later on in the discussion. But welcome to the show. First of all, I'll start with you. At my top left-hand corner, I have Amy Brown. Welcome.
Thank you. Thank you.
And in fact, I think I may want to ask you maybe get a little bit closer to you. It's kind of a little bit hard to hear you. There we go. Perfect. And then we have Dr. Jacqueline Hurd. Welcome to the show.
Hello. Thank you so much. I'm glad to be here.
Awesome. And then we also have Dr. Mona Gall. Welcome.
Welcome. Good afternoon and greetings from Texas.
Yes, absolutely. And what I'd like to do, those of you, as you're putting in where you're from in the comments, what city and state and country, I would like each of you to talk about a little bit about where you're from, like what area you're in, and a little bit about the scope of your organization. So let's start with you at the top left-hand corner, Amy.
Okay, can you hear me okay?
Yes, that's better.
Okay. I am in Lansing, Michigan, and I am at Sparrow Hospital. It's a 500 plus bed hospital, level 1 trauma center. We had quite a few COVID cases in the spring, and then we kind of dipped back down. And then we surged again, like probably many of you in the fall. And currently right now we're doing pretty good with just around 20. We've been at 20 for the past probably 2 months. So feels like we're finally starting to get back to kind of our regular day job.
Yes, that's a good thing. Awesome.
So hi, I'll go next. Hey, this is Jackie, and I'm from Atlanta, Georgia. So I am the Chief Nursing Officer at Grady Health System. Grady Health System is probably about a 950-bed academic safety net hospital located in Atlanta, Georgia. We are a level 1 trauma center. We are a comprehensive stroke and burn center. While we're in Atlanta, because of the specialty services that we provide, we receive patients from as far as Alabama and also North Carolina. So similar to what Amy stated, we saw our peak probably about March, and I think then we got probably as high as 150, with predominantly probably about more of the patients being in our ICUs. And similar to everyone else, our numbers went down, and we just peaked again in January, and we're starting to see those numbers go down. We were as high as 150 in Atlanta, and probably in the other states as well. The governor set up different areas in terms of where we could provide care to kind of help offset some of the patients in the hospital. So we were kind of sharing some of our patients, either they were on site at Grady or at what we call our Rural Congress Center, which was a pop-up hospital with about 50 beds.
Okay, very good. And Dr. Mona Gall, you next.
Yes, my name's Mona. I'm Associate Chief Nursing Officer here at Christus Mother Frances Health System in Tyler, Texas. We are located in Northeast Texas. We are about 500 plus bed regional center, not-for-profit, faith-based organization connected with Christus Health. Christus Health is based in Irving, Texas, with locations in Texas, Louisiana, New Mexico, and also overseas in South America. Just like what Jackie and Amy mentioned, it's been a year that we have, been part of the pandemic, and we have been running surges, peak volumes, running our census at 90 to 95% capacity, and really learn in a very, very quick manner, how we can be creative and adaptive to what was going on, making sure that we were serving our mission of, extending the healing ministry of Jesus Christ to our patients and, of course, our associates We have dealt with a lot of anxiety, a lot of concern, because we did not know how to deal with the disease early on. And, just being nimble learners and working with what we had from a resources standpoint and supporting each other. So I'm really excited to be amongst my nursing colleagues here this afternoon, because I'm also going to take down notes and continue to learn and be able to share, your best practices with our organization. So thank you.
That's wonderful. And speaking of that, because we did start to get into a nice little conversation before we went live, and it was interesting. The result we actually came up with a result that I didn't think it was even going to happen. If you don't mind, Dr. Hurd, can you touch on that, because you were asking about it, and then Amy responded about some information you were looking for.
Yes, absolutely. Thank you. So, the conversation that we were having earlier, as we're talking about COVID and during the peak, obviously we had to have restrictions in terms of visitation, especially earlier on around PPE and ensuring that we had enough PPE for our staff. And so ensuring that we were restricting or having exceptions in terms of the visitation. And as we're seeing with the increase in the vaccinations and our numbers starting to go down, it is time for us to really start having the conversation not only around current visitations and removing some of those exceptions, but really starting to have conversation regarding our COVID patients. As I reach to...
Sorry, keep going.
Oh, that's okay. As I reached out to other CNO colleagues across the nation, just trying to look at, and just like we're sharing today, it's always sharing within the nursing leadership to say, what are y'all doing? What can we do? Have you guys changed this? To find out if people have begun, or organizations have begun to open up their visitation. And it's interesting because what I found is that while they're opening and allowing 24/7, allowing 2 visitors to come in, no one is allowing visitation for our COVID patients, unless, which I think we all did, is like the only exception was end of life. And as we're coming out of this, I think it's important that we really began to look at how do we start opening up the visitation and allowing, especially our COVID patients. COVID is very scary. We know we were in a very dark time. And so when you're talking about patients who are in the hospital, obviously in the ICU, they may be very extremely sick and not alert, but some of our other patients that are not as acutely ill, but are in the hospital, how do we start making sure that they have that family connection and that support? Because we know when we talk about healing, it is also being able to be there with your family members. And, the thing that I think about regarding COVID is that, I've not had a family member or anyone that was sick or in the hospital during COVID. But I can't even begin to imagine if my son, my husband, my kids were hospitalized during COVID and were not able to have any visitation. And I do believe the long-term effects on that, we have no idea what that's going to look like. And so I was very happy to hear Amy state in terms of what they're doing. And I can tell you, I'm definitely going to reach out to her and get some of that information in terms of best practice, because I do believe it's time that we have to start allowing those exceptions as well.
Appreciate that. So how has that been working out, Amy?
Yeah, so back in the spring when things were more uncertain, we were allowing a couple people to visit in those end of life circumstances. And then our supply our supply was very good right now. We really, in the fall, we actually had our surge was, we had much more patients in the fall. We also had our mortality was not very good. Looked at a lot of different things, but one of the things that kept coming back is the fact that we had all these patients. We probably had about 140 to 150 at our top, and now 30 of them could have been in critical care, but the other 100, like you said, were very ill, and the COVID patients returned very quickly, so they might not.
I'm sorry, Amy. Amy, your voice is going out. It's hard for us to hear you. I don't know if there's a way you can get closer to your microphone. I apologize.
See if that helps. I'm sorry about that. So what we started to do in December was we use a PAPR, and so we have scheduled visits, and we have our patient experience person. She is working with the families, and she schedules them visits. We use our nursing leadership team to serve as escorts, and so they don't just get to come just go visit on their own. It's a scheduled visit. And so the nursing leadership signs up like from 2 to 4. They go down to the lobby, they go through the screening process, and then help them, put them in their PAPR, and then we take them up to the room. And so I was sharing on Christmas Eve, there was this woman who hadn't had any visitors in 20 days. And so it was her granddaughter that got to come visit. And we went in the room, and I said to her, I introduced myself, and it looks like you're in a spacesuit. And I said that I was a nurse leader here, and I said, I have someone special to visit with you. And she said, who? She couldn't recognize her granddaughter. And finally, when she got really close to her and she held her hand, I mean, she just started crying because she was just so excited to see one of her family. And so I mean, we have dozens and dozens of stories like that. And then we would wait on the floor, like I would wait on the floor, and then I would give them about an hour. And then we would, casually say, okay, it's time to go. And then we would go make sure that they docked all of their PPE correctly. And then we would clean the equipment, and then we would take them and escort them down to the lobby. And so our goal was to get every patient a visitor. And we definitely have done that. And then obviously some have already, some were able to do repeat visits. And I think, like that is the best medicine ever. So we have still continued to do that, even though our numbers have dropped. And like I said, I'd be happy to talk more about that with anyone. One of the things that we talked about is, do we do it for end of life or do we do it before? And I said, if we're going to do it for end of life, why wouldn't we do it before? And
I agree.
So there were a couple times where we were able to get in, the wife was able to get in and see her husband, and then they had to extubate him. So he was able to say, I love you. She was able to hear him, and they were able to have that exchange before he was intubated. And so that was my argument is, if we're going to do this, why would we wait until they're dying? Why wouldn't we do it when they're still alive and they have that fighting chance?
I wanted to share, thank you so much, Amy, for sharing that. Jackie, we also have a similar process. We call it COVID navigators. And this role was actually developed because of our desire not only to meet the needs of our end-of-life patients, but also majority of our COVID patients. So we started with one COVID navigator. She was a nurse who was able to connect with families and talk to them about when they would want to come to the hospital. And she provided education on donning and doffing of PPE, making sure that she answered questions of the family members. And then we were able to provide additional resources because our executive team saw that this was providing so much positive impact on our patient families who have not seen their family member for many days and weeks. So we were able to add 2 more COVID navigators and have started that actually in our pulmonary unit and critical care units, and we're able to bring it to other areas where we had COVID patients. And just like what you said, Jackie, this really is part of holistic healing, because we have received so many positive letters and emails from patient families who felt that they were no longer isolated, to be able to come see their loved one, and also helping the loved one with the healing process as a result of being able to see in person their family members.
That's wonderful.
I'm telling you, Rollis, that is outstanding. That is just, I get chills just hearing you ladies talk about that. Because I had just a real sad story when we talk about end of life, and a gentleman who had taken care of his wife. He was her primary caretaker, and by the time we were able to get him in to visit, she was in a coma, and he was just devastated because we hadn't allowed him to come in before. He didn't know whether or not she got everything that she needed, and he didn't get a chance to say goodbye. And so those are the things that the impact on mental health, that we have no idea of what that's going to do. I will say in Georgia, and this is what you're going to see happening in Georgia, we already have legislation that's coming up that's getting through the House regarding requiring and mandatory and allowing families to visit, even if it's only for an hour, regardless of what's going on. So we just need to be prepared. And so thank you all for sharing.
That's awesome. Thank you very much for sharing that. And so we got Patty is here. Welcome to the show, Patty Giuliano.
Hi, Patty.
You're muted, actually, Patty, and you're sideways. Awesome.
There we go.
And I think if you put it back, I think if you put it back sideways, I think it'll turn right now. See if it'll.
Okay, let's try it.
Yes, perfect. Okay. Awesome. Well, welcome. Thank you for being here.
Hey, thank you. It's exciting to be here again.
So I'd like you to quickly.
Sorry, I joined.
No, we understand, folks. We folks who are watching, if you're just not coming in, I have 4 CNOs. 3 of them are CNOs, and 1 is associate CNO, and we're all talking about staffing in terms of the nurses. We're talking about visitation. We're going to be talking about vaccinations here in a minute. Just a number of things that are kind of centered around that. And so, if you can, give us an idea of your scope, where you are physically, and then just a little bit about the hospital you work at. Patty, sorry.
Oh, sure. Absolutely. Actually, I'm fairly new in my role. I've been a CNO for a number of years, but recently I've just come down here to Texas, and I'm working in the Houston market with CHI. I'm actually down at the St. Luke's market in the southern end. And really, the scope of my role is to support all of the nursing services in 3 different hospitals, mentoring and working with the other CNOs. With all that we've been going through recently, of course, with COVID and vaccinations, masking and the protocols, and then staffing. So I've been responsible for really helping to manage the deployment of some of our, what they call them, star nurses down here, but they're nurses that are brought forward from the state, as well as some travel nurses that we've utilized. And now that we're seeing some of our patients, the population and the acuity has dropped just a little bit, we're looking at trying to stabilize some of our staffing. So I'm involved in all of the general nursing operations and some of the things as we, span the globe with the COVID pandemic.
Oh, very good. So thank you. So now we've got a good backgrounds for everyone as far as where you are. I want to move into vaccinations, if you don't mind, and let's talk about what that has been like. I know probably most of you start off with your staff first, and then we could also talk about how that's already worked its way into the community. Mona, would you like to start us off with that?
Sure. So thank you. As you mentioned, Rollis, we did start with our own associates, and we had some strugglers. I was calling, early adopters, and you have laggards. And I think majority of our associates were just waiting and to see what potential side effects would come from the vaccination administration. And I'm very happy to report that with the almost 2,000 associates, we have a total of 4,000 associates. The last count was we had very minimal associates who had side effects, and majority of those were mostly for those who have long-term allergy shots or comorbidities that would impact their ability to respond to the vaccine. And others is mostly due to anxiety. So we have had a very, very good turnout of associate vaccination. And what we have done is after the vaccination clinics that we had set up to make sure that we make room for social distancing and physical distancing, we have now moved that to our associate health. So our physicians, our nurses, and other clinical staff can actually go on their own time to our associate health to make sure that they obtain their vaccines. From a community perspective, one of our local ministries in Longview, Texas, has been selected to provide community vaccinations to about 16,000 community members. So they do that during the weekends and have been reaching out to our clinical nurses, even our retired nurses, to help with the vaccination clinics. Every so often, we would get some requests from our local public health department when we have vaccines that are about to expire. And you will not believe this, but we would be able to stand up vaccine clinics within 24 to 36 hours. Again, speaking to, the resilience of nurses and our work with our pharmacists to make sure that we're able to make use of those vaccines and not allow them to expire. So definitely we are on the right track in terms of vaccination. And so I'm just very happy and blessed. I feel that, I was one of those that have been able to take the vaccine during the earlier stages.
That's wonderful. But folks in the comments, if you would, let us know how things are going on where you are. How are the vaccinations going in terms of if you're working at a hospital, at the hospital level, as well as in the community. How about you, Amy? How are things going where you are?
I just got off a call not long ago, and we have about 9,000 caregivers, and we're at about 65% vaccinated. And so I think that, and it wasn't mandatory, so I feel pretty good about that. We've also given probably, I think, a total of, we're also vaccinating the community. We had we turned in an old drive-through auto oil change place. We turned that into a testing center.
Oh, wow.
When we started. And then when the testing volume was really going down in December, so we turned it into then a vaccine center. And so that's where we do the majority of our vaccines is through the drive-through. Instead of getting your oil changed, you get a vaccine.
I love it.
and they can run through people there very quickly. They can sign up and make appointments. The problem has been and like Mona shared too, we had, nursing leaders, the fact that they'll just do whatever you ask them. That's just, we not only did we go through a pandemic, but then all of a sudden now you have to vaccinate the whole world too. So the nurse leaders that I work with did a phenomenal job at just really jumping in and just really wanted to vaccinate the community. And so they've just doing a phenomenal job. I will tell you though, we're still really struggling with our minority population from a community aspect. And so that's been a concern of ours of what we could do different or better to reach out to the minorities in our community.
Well, speaking of that, Jacqueline, do you have some good advice on that as well as your update?
I wish I did. So, Grady, so our demographics of our patients, if you're familiar with Grady or Atlanta, are 60% of our employees are African American, and probably greater than 70% of our patients are African American. And so, as you know, Georgia's in the South. So we actually, before we actually started giving the vaccine, we wanted to survey our employees to see who was interested in getting the vaccine, who needed more information, and who just outright said no. So between those that were interested and wanted more information, we were probably at about 70%. So we're really trying to focus on those that were still on the fence, and about 30% just weren't going to get the vaccine. And so we have been obviously providing the vaccine and making it available to our employees. And we probably have about 6,000 employees, and we're probably only at about 47%. And so we are really continuing to work with them. Some of it is they just don't trust the science behind it and our timing. They just want to wait and see to make sure that, what are going to be the side effects of their colleagues. So we have many, many clinics that are associated with our organization. So while we're not providing it for the community per se, we're providing the vaccine for our patients that come through the clinic and the 65. So within that group, in terms of the patients that we're responsible for, we're probably at about 74%. And, we really are still trying to encourage, but again, when we look at the numbers across Georgia, in terms of the number of vaccines that have been given, we probably have given, in terms of first doses, about 1.3 million, probably about 800,000 in terms of for second dose. However, the percentage of African Americans is extremely low. And so a couple of weeks ago, we partnered with, I don't know if you all had a chance to see that, with Tyler Perry, in terms of really just interviewing him and getting him to talk about, he has some very solid questions regarding the vaccine, regarding the science, and really trying to get that information out to encourage our patients of color in our community in terms of getting the vaccine, because we know that is a community that is hit the hardest when we look at the number of deaths and the outcomes. So we still have more work to do around just education and talking about the science behind it.
Okay, thank you for that. Really appreciate that insight. Patty, how about from your perspective?
Can I ask a question?
Oh, sure. Go ahead, Amy.
One of the things that we tried is we worked with some community church leaders, and we went to the church, and before just showing up a vaccine, we really wanted to do some certification. But is that any type of strategy? Well, you guys said you're not vaccinating the community. I just wondered if that was another strategy or.
So yes, so we're using those strategies, and what we're trying to overcome, and especially in the South among African Americans, is just the history. That is so deeply, when you talk about the Tuskegee, which is so close to here in Alabama, when you talk about this Tuskegee syphilis research that was done, it's, that becomes a part. It sometimes is really hard to get into the roots and change that trust. And so that's why we're utilizing a lot of our churches, our African American healthcare providers, our African American leaders, just to talk about it and just to try and move beyond that. But it's very deeply seated in terms of trusting the healthcare professionals.
Yeah, absolutely. And I want to come back to that about that Tuskegee in just a minute. But Patty, go ahead and give us your update if you don't mind.
Yeah, it's interesting coming from a different market. I was up in the northern market up in Idaho, and they were doing remarkably well with getting the vaccine out and across the community to high-risk individuals, just getting things started and rolled out. Of course, all the healthcare providers and all the first responders and several different disciplines, law enforcement, they were doing a really nice job. Down here, I'm just beginning to start to see it, but not everybody is getting the vaccines that they're asking for as they're being disseminated out. Some of the larger hospitals are, but some of the smaller ones that are in my area, we all have to, go to the larger ones. They are bringing vaccines, and many of our staff have gotten vaccinated. We still haven't really hit that threshold yet because, again, they're in a shorter supply, but they are coming. This is not one of the testing sites that they're using for vaccination. So again, one of our larger Houston hospitals is providing all that. And again, demographically, because we do have a mixed population, with a Hispanic population, African Americans, and, it's important to get the vaccines out to everyone, especially those that are considered more in a high risk group. So I've just kind of scratched the surface down here, but I'll be very active and vocal in trying to make sure that we get that out to our community. And we're going to have some visitors tomorrow from the state government, which is kind of nice at our facility. And so we're going to be asking for their help to help us get those vaccines at some of these smaller community hospitals so we can get it out there.
So is your issue, Patty, more of a supply issue or more of an acceptance issue? Which one's bigger?
As I see it right now, it's a little bit of supply and demand because we just don't have the widespread, what you would call just density getting it out there. Healthcare workers are definitely accessible to getting it, but as we want to get it out there and start offering it to the community, like I did on the northern end of the United States, it's only at certain key select areas. It's not as easily, I think, obtainable. At least that's what I'm seeing. There is some pushback. Some people want to watch and wait and see what the effects of the vaccine are. But I haven't seen that as much as I did up north. Up north, it was kind of, we want to watch and see what it's going to do and how my coworker is. Down here, everybody seems very willing to get it. So it's a little bit more, they're more willing to get the vaccine, but it's just the accessibility for those outside of healthcare to get it. But all of our employees are responding very well to getting it.
Now, Mona, earlier, I think you were about to say something when we asked about a comment on getting the local church leaders involved. Did you want to share that thought?
Yes, I just wanted to share that, the 24, 36 hour, we had vaccines that were about to expire. We were able to make it happen because our church leaders in one of our local Baptist churches took on the challenge and worked with us, and we were able to meet the needs of their elderly patient population, mostly African American, very good group that were willing and able to make it. We had heavy rains on Monday, but they braved the rains, and I'm just so excited because they were able to come and we were able to give 300 plus vaccines. And when I went home that night, I was really, really tired. But to my mind, I felt that it was a great experience because we were able to make an impact on the lives of those 300 community residents who really needed the vaccine and did not have a way of getting it. It just so happened that we had available vaccines to give, and we had a team of people who were willing to leave their emails behind and be able to give vaccines. We also were able to work with Black Nurses, RAC, and the Greater East Texas Black Nurses Association. They came and were well represented. And just like what Jackie was saying, I think it really sends a very powerful message if you are working with the same group and you're able to identify, and there's that trust that is created. So we're just so privileged to have been able to do that for our community.
That's wonderful. We've got quite a few that have come in and are saying hello. We have, I know Meredith, she's coming in from Florida. We have Leah, she's coming in from Texas. Dr. Rosina Malaska, she's a fellow nurse. She's coming in from Indiana. And we had Casey Smith. He's also with the CHI organization. Patty, he had come in a little bit early. He's a nurse director there. And we have many others. So those who are watching, if you have any questions while we have this great panel on, feel free and put your questions in. Even if you're watching the replay, put your questions in, and we'll try and get all those questions answered. I'm going to hit the refresh button just to make sure I don't miss any more comments, because sometimes they don't come in real time. Let me just check that briefly here. Okay, we have Carrie Ann. She's also coming in. She said, Jackie. So Carrie Ann, Jacqueline, she says, I love those photos behind you. Yeah. And so Carrie Ann says, very similar here in Massachusetts. A few side effects, but I think she's probably saying something too bad or nothing too bad. Probably nothing too bad. About 60% vaccinated here in Braintree. Okay, very good. And Carrie Ann said, Amy Brown, that's a great idea. So she said something you said was a great idea. So maybe you can let us know what that is, Carrie Ann. So thank you for all your comments. Keep those coming in. I do want to just circle back to the Tuskegee thing. We've actually referred to that on another show, but we never actually explained it. And I feel like on one of these shows, I want to get somebody actually explaining it, because some people don't know about it, right? There's some of us who do. I don't want to assume everybody knows. So, Jacqueline, can you kind of give us a little bit of a brief history lesson on that?
So in a nutshell, and I'm originally from California, so I wasn't really familiar with the Tuskegee Institute because, I wasn't raised in the South. And I think the first time that I saw about it was a movie. And so basically and I can't remember the year, I don't have it specifically in front of me, but it was at a time when they had a cure for syphilis. And there was a study that was done out of Tuskegee, which is in Alabama, where they went into the community and they were seeking, they basically were telling these African American men that they would be treated, they would get free treatment for syphilis. So they brought them into the study, and basically what they did is they did not give them the treatment. And so what they were doing is with the African American men is that they were just seeing the impact. They were monitoring, they were doing bloods and they were checking them, but they were seeing the impact that syphilis would have when it was not treated. And the sad thing about it, at the time this study was occurring, there were already studies that were completed that before the cure came for syphilis, that they were aware of what would happen to someone that was not treated. So that whole distrust that these men thought that they were getting treatment for the bad blood is what they called it. And the sad thing about it that obviously came out much later, that they never received the treatment. And I think it was during Clinton's presidency where the United States government, gave an apology in terms of what happened. And as a result of that, then now, if any of you are doing any kind of research, whether it's in school or at your place of employment, it has to go through the federal government in terms of that whole IRB to ensure that those things don't happen again. So that is something that is very, very, very much deep rooted. And, again, when you talk about the Tuskegee, but you can kind of get into all the civil unrest and everything else that has happened in 2020 in terms of why, with your patients, your communities of color, that whole distrust.
Yeah, absolutely. Okay, so I just thank you for doing that. I just wanted to get have that on a recording somewhere, because we've talked about it a couple of times, but no one's actually ever explained it. So thank you for explaining that to me. You actually taught me a couple of things about it, so thank you for that. What are your just your observations on your nurse staff, your workers? Give me kind of a pulse as to what's going on right now, because we hear here and there things in the news. Obviously we're going to hear certain ends of the spectrum on the news. Mostly it's very, very I'm not going to say negative, but it's very tough, some of the things I'm seeing on the news. So I just want to know, from your standpoint, how are your staff going through all of this? Let's see, who would like to start on this one? You want to start, Amy? You want to start?
Sure.
Okay.
So, interestingly enough, I had a couple local reporters that wanted to interview some staff about burnout, and the managers talked to 6 nurses, and none of them wanted to talk about it. And I think that in itself just kind of I think they're tired of talking about it. I think they should talk about it. I think it's good for them, but I am worried because we did a lot of different things with regard to trying to help our nurses cope, mostly in the adult inpatient world, because that's where they were dealing with COVID and just the number of deaths they were seeing. I will say, though, is that we even brought mental health therapists to the hospital so that it was very, very easy. We bought massage chairs, we had snacks. I mean, I felt like we thought of everything, but I still think that there's some type of the person in itself still has to be willing to accept the help. And that's where I think that we found the most barrier, is that there are people, the nurses still didn't take advantage of those resources. So I am worried that it's going to come back and kind of, we're going to see some downstream effects. Where I'm struggling the most is honestly with my inpatient nursing leadership team. I've had quite a few resignations. They are choosing to stay at home with their kids. They're saying that the stress of the 24/7 was too much, and that they want to go back to that shift work. And so that's something that is definitely top of mind for me of how do I recruit nurses to go into this leadership role, because even in the spring, when the census dropped, the inpatient nursing leadership team, like I'm sure all of you guys, we never reduced our hours. We only increased our hours because we were preparing for all the protocols that we needed to do. So nursing leadership really has never had any downtime for over a year. And I truly think that they're just completely, I hate the use of this word, but burnt out.
Yeah, absolutely. Patty, how about from your perspective? What are you seeing? You can speak to your last organization or your new one, either one.
Yeah, it's interesting. In my last organization, I was able to be at a couple of different facilities, and it was actually heartbreaking in California. I was out there at a local facility for my prior organization, and I literally would go into the ICUs and just watch them prone patients just go down the line of 16 beds and prone, and then, 8 hours later, flipping back on their back. I listened and I talked to the staff when I was there because I was helping them with decompressing and trying to help with some of the expansions out of the ER. They had tents set up, and I couldn't just believe the positive candor of the nurses, but I know they wear it very heavily. And that was the hard part, listening to a nurse just talk about how while she was caring for a patient that was just really doing poorly and the team was in one room, another patient became dislodged from the ventilator, and she felt like it was her fault. And, it still kind of gets me choked up as I remember her telling me about that. And I said, you can't be everything to everyone, and you can't be everything if you don't take time for yourself. And it's been really traumatic. In other areas, and, now coming down to Texas, I think a lot of the nurses down here, at least in the facilities that I'm at, they've got a really good attitude. We just recognized a nurse with a Daisy Award yesterday, and the ICU team, the med surg floors, the ED, all those areas, they've been really very positive. I think they're starting to feel a little light at the end, but at the same time, you don't realize you're in combat until you're out of it. And I think going fast forward, we probably are going to see a little bit, or maybe a lot actually, of some PTSD in the months to year to come, as people finally can stop and separate and go, oh my God, what did I just go through? I liken it something similar that I had gone through with the Vegas shooting. You don't realize what you're in the middle of until it's over. And then you kind of realize, and it really helped. Well, I can't say it helps you, but it certainly makes you start to think about what are your priorities, what's really important in life. And I think that's why we're seeing some people step out of the field, because they're feeling that. But I will say, I can't compliment the staff everywhere I've been, and even just recently here enough, because watching them front lines, they've really done a tremendous job. And it's not like a true command center event, right? Because you have these emergency things and they happen quickly. This has been a year. So I think that's really just, the shape of things that we've seen to come. And to your point, like with the massage chairs, gift giving, things we can do. I mean, all those things are very helpful. But it really has been a stress on everybody, and physicians too, nursing assistants. I can't even say it's strictly nurses. I hate to single them out because there's so many people that contribute to the team. But I think in the wave of the months and year to come, we're going to see people's fatigue and stress as just sort of a new thing that they need to resolve.
Wow. So were you in the service area when that Las Vegas shooting happened?
Yeah, I actually was at Spring Valley. Yeah. And I was the CNO down there at the time. And it was just it was a very traumatic event. Very traumatic event. And, again, you talk about, reward. I watched nurses that night. A funny little story. Nurses that night at our hospital, we actually had an emergency situation. As the truck started rolling in with patients, we had someone coming into our emergency room with a knife threatening the staff. Oh. And you have a mass disaster, and you have the staff being confronted, which was a totally separate event most people don't know about. And I witnessed these nurses verbally assaulting the guy to get him the heck out of the way, because they had real problems. And it was like unlike anything you've ever seen. And then we never know where the guy with the knife went, but they thwarted that off. And then you just watch all these staff pour in and take care of these patients. And so going through that, the outpouring of the community, the staff resiliency, people came together. So yeah, I mean, it was unlike anything I'd ever experienced. And now we have this year of COVID. You go, my gosh, what else do we have to go through? So yeah, it was quite an event.
Wow. Okay, so before we move on, because that is on my list to talk about that violence against nurses. But before we do that, Mona, you haven't had a chance to talk on this particular topic we're on now. Did you want to share something on that?
Yeah, so Rollis, I just share what Amy and Patty shared, and I'm sure that Jackie also, echoes the same comments. Our healthcare team members have really been through a lot. Our chief nursing officer actually said in our annual report, who would ever have known that we will be serving in a pandemic? We were not prepared for a pandemic, and for each one of us, especially our clinical nurses who care for our patients directly, there's so many intangibles, things that we do not see that eventually will pile up and then will cause a burnout. And so and not just in the hospitals, not just in the patient care areas, the pandemic has really affected our families. People have lost jobs. We have to work from home. We had a reduction in force. Those kinds of financial and difficulties that can cause a lot of emotional and psychological stressors. So most definitely, just being there, supporting our team members, and really, there was an article that I read from a nurse leader, and what she said was resonated with me, because she said, do real rounding where you're really looking at the eyes of the clinical staff and really asking them, how are you doing? Is there anything that I can do to help you? And just really connecting with that person, and person to person, not even considering roles or positions in the organization, but really asking and connecting, what can I do to help you? And so I think my colleagues this afternoon share the same sentiment that, as nurse leaders, we really have to also, take care of ourselves, because then if the oxygen analogy in the airplane, if we don't take care of ourselves, how can we take care of all the people that are depending on us? So we have to also be role models of self-care, being able to care for ourselves, and also being vulnerable and honest that, yes, this is tough on us too as nurse leaders, that we do not come here with, special powers, not being affected by what's going on, and really showing vulnerability. And I think that's what matters to our team members, knowing that we're also human and going through this pandemic with them.
Yeah, absolutely. Now, Jacqueline, did I get your thoughts yet on this same topic?
The only comment, I completely agree with what everyone has shared. The only comment that, just to give a sense of, just when you talk about the nurse or either the physician being the hero, we all know what it feels like to wear that surgical mask, because we walk around, whether it's a surgical mask or in the community. But when you talk about the N95, the gowns, the glove, everything that they had to put on and wear for 12 hours, it is just, that's what you realize, that is amazing. When I have to put on the N95, I can't breathe. And so when my nurses, not only the goggles, the N95, and going into the patient's room and getting warm, to me, that is just, because it's completely different. It is amazing. And so when you ever see a nurse just getting a break to step outside in the lounge just to take the mask off to breathe, to me, that is, and that's why I'll say, wow, you guys are my heroes, because there is no way I don't think I could do in terms of that, and to wear that for 12 to 14 hours a day.
Yeah, I agree. So let me check in with the audience, see what they say. Let's see here. Yeah, I think they seem to agree with you here. So I there's some comments, and guys, I'm sorry, I'm a one-man show today in terms of the running the producer thing here, and I've noticed I missed a couple of comments. Let me just kind of get caught up here, and forgive me if I miss any. So let's see, Dr. Rosina Malaska, she says, excellent for church leaders stepping in. Dr. Erica Mills, also a nurse, as well as Dr. Malaska, she says, Erica Mills says, very well said, Dr. Hurd. As you stated, the apprehension is deeply rooted, so nurses have to be the leaders and change agents. We have unspeakable influence. That's a good point. Would you agree with that? Yeah. And then let's see here. Also, when you mentioned about the Tuskegee Airmen, she said the history of the Tuskegee Airmen, is that right? The Airmen is shameful. IRB is phenomenal in protecting populations involved in research studies. And she says, wow, when nurses go silent about what they're experiencing in this pandemic, it's worrisome. The long-term impact will be devastating. Dr. Mills agrees with her. And she says, now, Dr. Molasses, she's one of those frontline nurses. She's doing travel assignments right now because I know her personally. She says many of us at the front lines are hiding it in order to survive the day, but PTSD will hit us in the years to come. So Patty, she echoed your thoughts there. And Dr. Mills said the resiliency model has been helpful for communities and healthcare centers. So those are the comments I have so far as what you're saying. I do want to touch base on this violence against nurses, but before we do that, I want to do something a little bit fun, really fast, because we're running out of time here. I'm going to ask you a would you rather question. Okay, let's do that. It's been a while since we did that on the show. Okay, so would you rather, I had it up here, where did it go? Oh, here we go. I had a special one for you. Okay, here we go. Would you rather be able to move objects with your mind or make them disappear? Who wants to take that one first?
I want to make them disappear.
Okay. Okay, why do you want to make them disappear? Why, Mona?
You should see my email inbox. I have like thousands of emails. I had to take PTO and, just for mental health. And then when I came back, well, people still kept sending the emails. And so sometimes I wish I would make it all disappear.
I understand. Okay, and I saw Jacqueline. I saw your mute go off there. You were going to say something too. Go ahead.
Yeah, I said I think I'd rather make them move with my mind because again, I may not need them to disappear, but I just need them to move out of the way.
Okay.
That I can just I still may need them, but let me just move them over, move those barriers, those roadblocks, just kind of move them out of the way. So I would say with my mind. Okay.
All right. Amy, what about you?
Yeah, I was gonna go with Mona, but now I'm thinking along her lines of imagine if you could move them with your mind and get them to do the things that you need them to do. So I'd say that.
Okay. All right. Very good. And Patty, what about you?
Oh, definitely with my mind. I think that's kind of powerful, right? Like you go over here, you go over here. It'd be very efficient. I think it'd be kind of fun.
Okay. All right. Very good. And those in the comments, let us know what you guys think. Which one you would pick. Okay. I have one more for you. And who wants to be brave and take this one? It's gonna be fun. It's a fun one. Who wants to? Okay. Amy's gonna go first. Okay. So Amy, would you rather have a light bulb appear over your head whenever you have an idea, or have speech bubbles appear whenever you say something?
Well, I like speech bubbles.
Okay. Why is that?
I don't know, because I think it would just, it looks like one of those memes where it would just appear.
Exactly. Yeah, exactly. Okay. So Jacqueline, what would you do? Which one would you take?
I think I would say the light bulb. And the reason I would say the light bulb is that people would already know, okay, here she comes. She's got an idea.
Yeah, I like that one too. Patty, what would you say?
I think I'm going to go with the bubbles, simply because my mind is just constantly going, and I think there's probably too much for just one light bulb or two light bulbs. So I'll go with the bubbles.
Okay, the speech bubbles. Okay. And Mona, how about you?
I'll go with the light bulbs. Only because we haven't had electricity because of the snowstorm. So I think that's going to help my co-Texans when they see the light bulb, knowing that light is coming.
Yeah. Very good. Well, boy, I tell you, this is crazy. The hour we're almost to the end. I have so much stuff to talk about, so we're going to have to do like a part 2 to this thing. Okay, and I have several comments here. So let me just kind of make sure I just touch base on those. Okay, Dr. Malaxa, she says, all healthcare workers are affected, but she says we night nurses are tough. She says she says resilience is helping us cope day to day for now, but she says absolutely self-care in healthcare is key. And also I see another one here. Okay, Malaska says, would you rather? She says, for me, she'd rather make them disappear. She can go back to some resemblance of normalcy. Okay, all right. Carrie Ann says the light bulb. Okay, so I missed a few comments here. So sorry if I missed your comments today. All right, so I'm gonna have to skip the violence topic, I think, unless you briefly, Dr. Hurd, you want to say something about it, because I want to finish up with what can we do that's positive, that can positively impact a nurse and make them feel a little bit better. But tell you what, Dr. Hurd, in case you want to comment on the violence against nurses first, and then go with your comment. How about that?
I'm sorry, which comment was that? Commenting on
about the violence against nurses. That's an issue that we need to have a show on that, actually, and how we can counteract that.
I would agree. I think that would be definitely a show. I think we talked about that earlier regarding violence against nurses, kind of like the hero, and that nurses don't report it because they feel like this is what I sign on, this is what I'm supposed to do. And, we have to really encourage our nurses to report it, because we can't begin to address the issues. And that is in itself, when we talk about PSD, and it's very traumatic. I don't think people realize how traumatic, whether it's not only just in the emergency department or in the behavioral health. You can kind of sometimes anticipate or expect it in those areas. But when you're talking about the inpatient areas, people may not even realize in terms of the violence, even in women's services. So, something that we do need to talk about and really get people to comfortable to report it, and not to say this is what I signed on for, because that's not what we signed on for.
Yes, thank you for that. And do you want to give any advice quickly on what we could say or do to positively impact the nurse, either as a nurse leader, as a person in the community, anything you want to touch on that?
I would just say in terms of, and I think, Mona, I've heard several of the nurses of my colleagues speak to that, the most important thing during a crisis is for nurse leaders to be, and I think Patty talked about it as well, is to be visible. To be visible, to be out there. This is not the time to be hiding in your office because you're afraid of getting COVID. It is being out there, is asking, do you have enough PPE? What do you need? It's being out there, because they see us, believe it or not, as that hero in terms of, the CNO or the nurse leadership had the time to come by and say, hey, how you doing? How are the kids? So I think that is the most important thing that we can do as nurse leaders. And it's tough, but I think it's also important to help to have that conversation, to remind our nurses why you got into nursing. This is what we signed on for. And just remember, when you made that decision in terms of what is your purpose, and it brings it all back in terms of and of course, work-life balance, I'm pretty sure others will talk to. So to give everyone else a chance to talk, those are the words of encouragement that I would definitely give to our nurses.
Patty, you want to give us a quick brief thought?
Yeah, I guess just even to echo back on that, truly, really being out there and visible is really important, like we said earlier, and validating and recognizing them in the moment, just letting them know what a great job they're doing. I think oftentimes we're critical, and we don't mean to be, but, we always give them the but, and there shouldn't be any but at this point. I mean, there's a time and a place to give, constructive feedback, but to be a leader and to round really should be about recognizing the successes in the moment. And I think at least that's some of the things I've seen, and especially here where I'm at now, it's such a happy environment. And there are other happy, pleasant environments, because it's a tough world right now, tough job. And if we can all just, you love these folks for, hey, great catch. Hey, great, great to see what you're doing. We really try to make a list of all the kudos every day. And I think now more than ever, it's really important, but really validating. I think so.
By the way, I just got a comment that Erica Mills, Dr. Mills, says she would attend that workplace violence one for sure. So we definitely have to do that again. Okay, Mona, go ahead. You have a brief thought you want to share?
I echo what Jackie and Patty shared. Just being visible and being supportive and asking, what matters. Be having a purpose and just being reminded of that purpose is very important.
Absolutely. And Amy, you want to finish this out?
Yeah, I just one of the things that I started to do quite a while ago is at our safety call when we hear about a caregiver assault. The director sends me their phone number and I call them and I just say, this is a CNO, I'm just checking in on you. How are you doing? And they've just, wow, I can't believe you called me. And, it's just like you said, I'm just checking in. How are you doing? And then I always follow it up with is, are you going to feel okay to come back to work? And what's that going to look like? Because, that's, I've been assaulted before at work. And it's very scary.
Oh, wow. Okay. So we have to have y'all back to do we have to do that show on the workplace violence. And I just want to check with my audience, see how they felt about these comments you guys just made. Wow. They seem to be pretty excited about it. You see that? Okay. Very good. Well, thank you very much. This is a wonderful show. I love it. You guys are doing such amazing work. All of your staff are doing amazing work. Thank you for everything that you do. And we're definitely going to get this back on the schedule here to episode 2. We're going to delve into this topic about how we can address the violence against nurses, because that is something that apparently is a needed subject to discuss. Would you guys not agree?
Oh, absolutely.
Okay. Well, thank you everyone for watching. Thank you for watching today. Please come back and see us next week. We'll be back. We'll have a Monday show all the way through Thursday at 2:00. And then if you want to catch another roundtable, that'll be next Thursday. So come back and see us next Thursday. Thank you for watching. And let's say bye to everyone. Bye, everyone.
Bye, everyone. Thanks, Rollis.
And then if you can, hold on for one quick second, and I'll just make sure it's clear for us to cut it off here. 1 second here. Everybody's saying thank you, by the way.
I took a selfie of everyone.
Oh, did you? Okay, cool.
Good for you.
I love it. I love it.
Rollis, I just want to say thank you for having us because, when you're the CNO, you often feel isolated, and just being with other people like this is it's very reassuring. And so it fills my bucket. So thank you very much.
Awesome.
Thank
I
you.
love that. Oh,
Yeah,
man, you made me feel
very
good.
nice. I agree.
Oh, I have to give you this right here. So I have to give you that. Thank you very much. Thank you. Okay. All right. So